Well, hello everyone. It's a great pleasure to host the next ERA Journal Club, and it's my great pleasure to have a bit of different topic than we usually have. So we are talking about using artificial intelligence to predict mortality in AKI patients, a systematic review meta-analysis, which has been published in the Clinical Kidney Journal. And it's my great pleasure to have one of the authors, the Dr. Rupesh Raina from the US here with me. So he just told us that he's both a trained pediatric and adult nephrologist. And I have a great panelist comprising Professor Greet de Vlieger from Leuven, Belgium, and Professor Wisit Cheungpasitporn from the Mayo Clinic in the USA to join us. And we will try to guide you through this journal club. And with this, I'm handing over to Dr. Raina for the presentation.
So good morning, good afternoon, good evening with the different time zones. Thank you for giving me an opportunity for presenting our journal club on the articles on AI. My special thanks to the ERA, the leading European Nephrology Society, for giving me an opportunity to present the journal club. These are my disclosures, and I'm actually a member of IPNA and IPTA and ISN and ASN. So today we're going to talk about using the artificial intelligence to predict the mortality in AKI patients. And we did a systematic review. I want to be very clear, our intentions for this analysis was just looking at the mortality in the setting of AKI. So if you look into the AKI affect around 15% of the hospitalized patients and 30 to 60% of patients in ICU. And CRRT is a renal support. Now we have taken the renal replacement to renal support, new terminology, and actually the mortality with CRRT goes up to like 30 to 70%. There's a lot of advancement with the early identification of the AKI, which led to the better intervention, decreased mortality, morbidity, and efficient resource allocation. And that I'm going to discuss about the studies and length of stay in hospital and expense. If you go back to the study, the background about the AI, which is also a learning curve for all of us as a clinician, previous studies have evaluated the prognostic models that employ both conventional statistics and advanced artificial intelligence modeling technique like machine learning. So if you look into the machine learning, you have deep learning, you have supervised and unsupervised. And then you have linear machine learning model, which include logistic regression or linear regression, which is aimed to understand the relationship between the variables, which can be affected by the factors of multi-collinearities. Basically, it's more or less like a logistic regression, the way we use in our statistical model. There are also advanced non-linear modeling technique, which is growing along. It's a random forest, XGBoost, broad learning system, support vector machine, and I think on the left side of the slide I've shown how those are can be divided in the banner or the under the artificial intelligence. Now the aim of this study was to compare the performance of different machine learning and AI modeling in predicting in-hospital mortality of the patient with established AKI. When we were doing the study, we have to concise our hypothesis to be very particular because there are a lot of studies in AKI and there's a lot of studies done for the sepsis, AI modeling. Our group intention was, okay, what are the AI modules that I can use to predict the mortality? So we did a data search, which has been very much presented here in the slide, which is under the study design and search strategy. One thing is very important for you to including what articles that we included. We used the original study reporting the performance of AI and machine learning models in predicting in-hospital mortality of AKI patients. Studies that include metrics of model efficiency, such as area under the curve, accuracy, sensitivity, specificity, negative predictive value, and positive predictive value. We were very particular in looking and identifying our data from the studies which are cross-sectional, prospective, and a retrospective study design. And the exclusion criteria were reviews, meta-analysis, editorial commentaries, and self-reported outcome. Non-original studies and studies without sufficient data on model performance metrics, we have ruled it out. If you look into our data analysis. It is in the, it's all written there about the data extraction and quality. One thing we did was, what was the extracted information include? We study the characteristic author year publication studies, a sample design and patient demographic, but we were very detailed AI and ML machine learning modeling used, like what kind of model type, what are the features which is including, what is the training and validation method they use in this study. We use the performing metrics, AUC, accuracy, sensitivity, specificity, NPP, and PBV. We used all these parameters, and I'll go over with the results to show you what are the performance metrics that could help in predicting. And the quality assessment was basically based on the methodological rigor and risk bias in the study involved in AI and ML models. These are statistical analysis. So we want to be very diligent about how we do the comparative analysis, because when you look into this various AI models, you need to look for the comparative analysis, which also has an endpoint of mortality. So you are actually doing a comparative analysis, putting an endpoint to the crude mortality risk. So what we did a DeLong test, which was used to compare area under the curve value of different model to identify statistical significant difference. We did a subgroup analysis to explore the potential source of heterogeneity. And we were just talking before the seminar, as there is a lot of heterogeneity on these settings. There are centers which are tertiary level centers. There are centers which are sepsis AKI in a different setting. There are centers who have an AKI with infection. So the heterogeneity, such as difference in patient population, study design, and model characteristic, was taken into account. One thing was very, very hard in this study was how to handle the heterogeneity. And we were very particular, our group, that we have assessed the heterogeneity using the I-squared statistic within values of more than 50%, indicating substantial heterogeneity. And we did the sensitivity analysis to evaluate the robustness of the pool estimate. Now, this is a review, a systematic review and meta-analysis, so no ethical approval was necessary. It was registered in some of the software. The review was conducted in according to our PRISMA guideline to ensure transparency and reproducibility, and the detailed material method section outlined rigorous approach to review and analyze the performance of AI and ML model in predicting in-hospital mortality for AKI. So just to summarize material method, PubMed and Embase database, these are some of the primary search queries, include study intel performance metrics of AI. These are the model predicting in hospital AKI. And these are some pool analysis, heterogeneity, forest plots, eager test for publication bias. DeLong test was used to compare the receiver operating characteristic of two models. Full data analysis can be found in the paper if you want to look. I made this study very clear, like what are the 8 studies we took? One study was with COVID-19, 2 study AKI on CRRT, 1 study was cardiac, and 4 was other causes. When we pooled the data, there were around 37,032 patients in total, and mean age was 65, and in-hospital mortality was 19.8. If you look into the various literature, it is around 15 to 16. Our setting was more in the setting of the ICU in hospital, so it was 19.8. To make it very simple, this is the best way I put it, total 14 different machine learning and AI models were reported in these studies. And to make it very clear, I kind of made a very good pictorial diagram to show you. We used logistic regression, random forest, support vector model, XGBoost, elastic net final, which I'm going to talk more about, SAPS, SOFA, Mosaic model, Apache, multivariate adaptive regression. This is a very fascinating part of our data analysis. When we were sitting down and doing this systematic review, looking into our criteria, as I mentioned, I was very strict to put the criteria in. We were concerned narrowing it to 8. Are we going to have different machine learning and AI modeling? And you can see almost all kind of modeling was represented with these 37,032 patients in total. So results, number of the studies were 8. Total patient, as I said, was 37,032. The average age of patient was 65. The in-hospital mortality in the derivation cohort was 18, and in the validation cohort was 15.8, which is most of the literature has said about the AKI mortality in sepsis or other setting in a hospital is 15%. Now, when we looked into the model performance, broad learning system, elastic net final, proposed clinic model. I'm going to specify this again, BLS, which I'm not going to spell that again. It's broad learning system. So I'll be saying that as BLS. E and F is the elastic net final, and proposed clinical model is PCM. And a variety of ML model were included in review, each demonstrating a varying degree of predictive performance. But see the pool AUC and the 95% of the confidence interval. The BLS has 0.85, E and F has 0.85, to almost comparable, and PCM, which is proposed clinical model, was 0.76. We did the comparative analysis. The pool AUC of BLS and ENF did not show significant difference from other model except the PCM. And D-long test, significant difference between BLS, ENF, and PCM was p-value of 0.002. PCM is, as a rule-out tool, had highest negative predictive value among all models, making it particularly useful for ruling out in-hospital mortality risk. When you look into the sensitivity and specificity, BLS and ENF models display balanced sensitivity and specificity, contributing to their overall high performance in predicting the mortality. While PCM model has a low AUC, its high negative predictive value, strong performance in identifying patients unlikely to die in the hospital. So this was a nice analysis if you interpret in a clinical aspect, if I have to use a PCM model, it has a low AUC. So it's all not about AUC all the time, but it has a high negative predictive value, indicate strong performance in identifying a patient which is unlikely to die in the hospital. So you can predict, well, the mortality will be less. But if you look into the BLS and ENF, they have balanced sensitivity, specificity, but they have more value in predicting the mortality. So when we did the predictive value metrics, it varied across different models, was not heightened as a top performing metrics for any specific model. Negative predictive value was highest for PCM, suggesting its utility in clinical setting where ruling out mortality is crucial. So you have to be careful when you're using these models. Are you looking for predicting the mortality? Then you go for BLS and ENF, but you're looking for identifying patient unlikely to die in the hospital or utility in clinical setting where ruling out mortality is crucial. It is actually the PCM. Now, these are some of the forest plot, which you'll see about RF model, BLS model, ENF model, XGBoost, SVM, ANN, LMP model, PCM, AUC across different study. The lower diamond in each graph represents the pool analysis. We need more study to prove that. But if you see, each square represents the AUC value of a study, indicating how well the model is distinguished between patients who will survive and those who will not. Confidence intervals was the horizontal line to the square representation of the 95% confidence interval, which indicate the range of uncertainty around the AUC value. Then the diamond at the bottom of each plot represent combined AUC value from all the study, providing an overall estimate of the model performance. So the conclusion was with this forest plot was the plot provide a visual comparison of different ML model effectiveness in predicting in-hospital mortality for AKI. And this is exactly how this has been represented in the diagram. If you look into the broad result, the in-hospital mortality was 18 in the derivation and 15 in a validation cohort, which is very much comparable to the other studies. Although our patient mean age was around 65 years, the pool AUC with 95% confidence interval was highest for the broad learning system mode and the elastic net final model, and the lowest for the proposed clinical model. The pool AUC of BLS and ENF did not differ significantly from the model except for the PCM, which is D-long test. The PCM exhibit the highest negative predictive value, indicating its potential used to rule out as a tool for AKI. Now, this is a nice diagram which you can see the results area under the curve. And I'll explain you that the broad learning system, BLF, and elastic net final model exhibit the highest pool AUC value of 0.852, indicating a superior predictive performance. Now, these models of AUC did not significantly differ from each other or from most of the other models, except for the PCM, which has a lowest AUC. Logistic regression also show high performance of pool AUC of 0.837. The result underscores the variability in model efficacy, with BLS and ENF standing out as a model to predict the mortality in patient, even maintaining the heterogeneity of the population. But again, people have looked into the studies before. Proposed clinical model is not good for predicting mortality, but it has low AUC, but that is also has a high NPV, so maybe can be used to rule out not to have a mortality with an AKI. Now, if you see the table 2, it represents the meta-analysis and sensitivity of the different machine learning AI model in predicting in-hospital mortality. The random forest model shows the highest pool sensitivity, indicating its superior the ability to correctly identify patients who will die in the hospital, while other models, BLS and SVM, demonstrate varying degree of sensitivity. If you see table 3, it shows a meta-analysis of different ML and AI model in assessing in-hospital mortality among AKI patients, with ANN and MLP model having highest pool specificity, indicating its strong ability to correctly identify the patient who will survive. So table 2 demonstrate various identify patients who will die in the hospital, and table 3 showing strong ability to correctly identify the patient who will survive. And those are ANN and MLP. These charts or these analysis is very, very informational if you read and if you have to pick up a study to look into the AI modeling. Now, this is a meta-analysis of NPV and PPV. Table 5 shows a meta-analysis of negative predictive value of different ML and AI modeling for assessing in-hospital mortality among AKI patients, with PCM strong highest pool NPV, indicating its strong capability to correctly identify patients who will survive. So that's a model that you will actually look for if you have to indicate it for a strong capability to correctly identify the patient who will survive. Table 6 represents a meta-analysis of positive predictive value of all the machine learning and AI model for assessing in-hospital mortality among AKI patients, with the BLS model demonstrate the highest pool PPV, indicating the strong ability to correctly identify the patient who will not survive. This was a very nice way of doing the meta-analysis to look for NPV and PVP. And I said initially in my material method, we have used all the available AUC, NPV, PVV, sensitivity analysis to come up with the outcome to direct you or give you an armamentarium for what AI model that you should be looking in an in-hospital setting with heterogeneity. Now, this is the meta-analysis of accuracy of different machine learning AI model in assessing the in-hospital mortality among AKI patients, with BLS model achieving the highest pool accuracy, strong overall performance in correctly predicting both survival and the mortality. And this is something was nice to look into these models with the meta-analysis of different ML and AI models. Now, interpretation, top performers, BLS and ENF models are the top performer in predicting hospital mortality for AKI, with AUC value indicating strong predicting accuracy. Utility of the PCM, despite its lower AUC, PCM has a high NPV, is valuable for the clinical decision making, particularly for excluding the patient at low risk of mortality. Model selection. The choice of model depends on the clinical context and the specific need for the healthcare setting, such as the emphasis on ruling out mortality versus identifying high risk patient. And this is the important part of this paper, is most of the time when you go and look at the data and pick up the AI modeling, you have to have maybe the AUC is low, but the NPV is high. So you may be looking the exclusion of the patient with low risk of mortality. When you look at the high AUC and low NPV, but you are looking for a strong predictive accuracy of mortality. So model selection was something you have to take into consideration when you're looking at your questions in an AI modeling in in the AKI setting. This review underscores the potential of AI and NM and the machine learning model in improving mortality prediction for AI patient, with BLS and ERF model is showing the highest overall performance. However, the variability model efficacy suggests the need for continued research to optimize these tools for a diverse clinical setting, clinical application. These models have not been used into the place where people have limited resources, where you can be having AKI due to the infection if you go to the low middle income country, or you can go to places where people are having a sepsis, multi-system organ failure, maybe another pandemic. So you need to have a variability in the models, which efficacy suggests we need to have a research tool for these diverse clinical application. And unfortunately, we do not know which model we should look in the various different diverse clinical settings. Take-home points from the paper: high mortality risk, acute AKI is associated with significant in-hospital mortality, hiding the need of effective prediction model. I have published the paper changing renal replacement to renal support. We don't want to wait till you have fluid overload, acidosis. Maybe you need ARDS network study. Maybe start for fluid overload more than 20%. You may need TPN. You may need exogenous IV intake. Maybe we need to start changing our paradigm. AI and ML advancement, the use of artificial intelligence and machine learning has improved the ability to predict in-hospital mortality for AKI, providing more dynamic and accurate models. Now, top performing models were the broad learning system and elastic net final demonstrate the highest predictive with AUC of 0.85, means it will tell who will die with an AKI. But take into account the proposed clinical model, because most of the AI modeling saying that the PCM or proposed clinical models has limited efficacy, but it shows the highest negative predictive value, making it a potential tool for ruling out mortality risk in AKI. So maybe that's the model you need when you sit down with the patient, seeing with the AKI on CRRT to rule out the mortality. There is a model variability. While both the broad learning system and elastic net final models are effective, there is variability across different ML models in predicting mortality, indicating the need for tailored approach in different clinical settings. AKI is a dynamic process. It's multifactorial. It's hemodynamic. There is what we call is a chemokine burst. So those models can be tailored to a different clinical setting is the need. Need for future research, additional studies are necessary to validate and refine these predictive models, ensuring that they can be reliably applied across the diverse population and clinical setting. Now, key learning point, this is from my paper, that's a box that goes with CKJ. Acute kidney injury in hospital mortality rate have increased over the past decade. Many machine learning and AI tools have been developed to predict the mortality in patients with AKI. This study ad using 8 varying AI model used to predict mortality in patients with AKI. There was no clear discriminatory results between the models. Potential impact, the results present in this manuscript outline that clinicians should use AI model to predict mortality with caution and be wary of potential bias and limitation, but also that they should be used a tool that is more generalizable to their patient. Thank you for your time.
Thank you, Dr. Raina. That was amazing overview of the study and also of the methods used. Just something out of curiosity before going into more detailed questions. So how can we implement like AI and machine learning tools into our electronic healthcare resources? Do you have any experience here?
So good question. So we have Epic, and I'm showing Dr. Wisit has the same EMR Epic system. The problem is we are trying to put this 2 models that I talked about for the predicting the mortality in the setting of the ICU, there's a lot of variability and there's a lot of heterogeneity. So what you see is when you put these models into any of the EMR, it just takes the mapping because it takes the variable that they want. Now they may miss the sepsis because of infection. They may miss the sepsis because of heart failure, they cardiogenic, or they miss the sepsis or ARDS because of the IV drug use. So that is a problem of the heterogeneity. So what I would have suggest, these models are not ready to put it in any of the EMR because of the mapping. Unless you really look into the data and try to put all the models that you have to see what your question is, it will be very hard for the AI system to put, at least in the Epic, and Dr. Visit can comment on that, to make it a generalizable outcome. If you say your mortality is 70%, but you don't know it is due to the ARDS because of infection versus drug use versus sepsis, if you look into the data, the mortality is different in every setting, as Dr. Vlieger was saying before. One thing I really want to tell the people is AUC, AUC, AUC. I understand, but look into the negative predictive value for the models too. Because sometimes you have to say, hey, you're dying. They know they are in ICU, they're ventilated, they're dying on CRRT. But it's always good to look and say, hey, your chances of mortality is actually lower as compared to this patient because of these model that I'm using. And that's why the PCM we did. And when I was doing the analysis, it was hard to sit down with your AI team. I said, I understand mortality. I want to also know which model can predict to say the mortality is low. Dr. Visit, do you want to comment on any of the EMR putting the modeling? You know, you have a Epic too. It's a challenge.
Yes, thank you. And if that's okay, if I discuss a little bit about this. So, nice presentation, Dr. Raina. I really enjoy your presentation, and the I like the AI, and also I think integration AI into like clinical workflow is in the future. I think it will happen. The using the current models into the EHR is not ready yet, but we are preparing to be ready because likely gonna happening soon. uh, with the models for machine learning models and traditional approach, as we know that machine learning models, they able to handle like complex data better, like data complexities. And nowadays, the with everyday life and more, and later on, we our data tend to be more complex. We have like molecular based data, we have urine biomarkers, we have the imaging, and all together with traditional approaches cannot put all of this the complexity of the data in. And also like with the big database, this will make the machine learning models to like outperform traditional models. Not now, even if it's not now, then it will be very soon or the near future. So at Mayo Clinic, we also use electronic health record with Apex. We the have our the prediction models as well. We but what we're doing is we have ongoing efforts to do the cloud-based system, like making the data, the putting our data into the secure cloud of our institution. And then we will have like live data. That's not only like the data from the admission, but the data from like minute by minute, day by day. And then we trying to create the machine learning models that can apply into that the cloud-based system, and will be secured and will be live. And or we can call this as the dynamic machine learning model instead of like static model.
Right.
Like the studies that included in your nice paper that you the summarize, they are great, but they are all the static models in which they use the data at one point to predict the outcome. And as we know that day by day basis, our data change all the time, and we need more of the dynamic data And what our effort that we're trying to do, I'm trying not to be too long, is to make it as a cloud base, and then live data and dynamic the models, and of course need uh, in addition to the performance of the training, we need to look into the validation and external validation and multi-site validation as well. Yeah.
Well, let's go over to the questions we have in the chat. So the first one is, were the prognostic factors the same in the 8 models? That's a very good point.
No, there's the prognostic. Again, our outcome, again, I want to reemphasize, when we started, we're looking into the model that can predict the mortality in AKI. So the 2 ones which I mentioned was performing very well. So all the 8 models, AUC, as I showed in my slide, the 2 which I showed you are outperforming. Those are the BLF and the other 2 that I showed it to you. They are more effective than any other model. BLS and the one was the broad learning system, BLS model, and the elastic net final was performing better for the mortality in AKI. But if you look into the model that will rule out, or that will tell you that you have less likely of dying of the AKI, was actually the proposed clinical model, which is very different. When we were looking, and I was like surprised to have proposed clinical model, because proposed clinical model can have a lot of confounders, because Dr. Wisit or Dr. Kronbichler or Dr. Vlieger can say, I want a proposed model for regression. I want outcome at 3 days. I want an outcome for 7 days. I want an outcome for 24 hours. So the proposed clinical model was more predictive of the mortality, like to tell which patient are not going to die with the AKI. I hope I answered the question.
And there is another one in the chat. The AKI mortality increased over the years. Is there any obvious explanation for that?
Yes, very big explanation. If we round with our senior attendings. I did my fellowship in 2010 in clinic. At that time, do you know that anybody knows about the Akin classification? Anybody was making point for creatinine going up from 0.3? We were called when you see acidosis, hyperkalemia, fluid overload. We were vigilant looking into the fluid overload. This is the data from PEDS. More than 20%, they call us. So there is more awareness, more tools to identify AKI earlier as compared to the past decades. It's not increasing. It's basically you have a tool to identify. And I always say that when I do my talks. If I am presenting in Dr. Vlieger as a visiting professor and I say to her in her hospital, I have a chest pain, she won't let me fly. I have to go to the ER to do 3 serial troponin, maybe an echo before I go out. But there is no renal angina that you can call in for. So it is not increasing mortality. It's an awareness. It was there before. As you can see, the mortality is going down. Renal replacement is changed to renal support. People are acting more earlier as compared to, and this is my generation gap. When I graduated till now in 2024, people are more vigilant. There is a ninja program where we are identifying more nephrotoxin, fluid overload. People call us before the bone marrow transplant. People are getting vigilant because now the CMS, and Dr. Wisit knows that, is going to come and look for your performance. So maybe the AKI is causing long-term stay, more LOS, more mortality. So people are getting more quality driven than looking at the treatment specific. So whenever anybody says mortality is going high, I say, no, it is not going high. It is more recognized now. So I want to emphasize people. And then you have new infections, new things coming up. You have pandemic. So you have no control on the exogenous factors that can potentiate AKI. But you're also looking on subtle marker like urine output. Within 4 hours, if you have no urine output, you get caught. initially nobody called you for 48 hours unless your fluid overload with 40% and on vent. I hope I made this point very clear because I'm very sensitive. I'll send you my paper that I published is renal replacement has to change to renal support. I don't know, Dr. Vlieger, do you think that it's more identification? People are more what I will say is more looking for these parameters for AKI as compared to the incidence coming higher up?
Was it to me? I just didn't recognize my name very good. So I'm Dr. De Vlieger. Yeah, I do think that we have a lot of awareness now about AKI, and we also see it in the conferences. There's more and more interest for AKI during the latest decades. So I really think that we are, in fact, improving. But I also think that we have sicker patients, especially in the ICU. People can survive some acute diseases, and in these patients maybe we see a mortality that is associated with AKI that we didn't see before because we were just, the patient died already before we saw that AKI was present. So
right.
Yeah, I think one of the pressing questions also in the chat now coming up, and also the questions passed over to us before, is I mean, apart from Epic, where you get the AKI alert, and that is basically AI driven, I think where has AI been empowered or integrated in clinical practice so far, and where do you see the immediate potential?
I think I can maybe answer this question a little bit more from the European side, because we are really trying to implement these things, but in Europe, it might be even more difficult because of the legal and the ethical concerns. So we really try to implement some machine learning tools that we developed in our patients, but you need to have first a prospective comparison, and you need all these patients signing an informed consent for these studies. And then you have this medical device regulation where you cannot update your models. And in fact, this is the very interesting thing about this machine learning, that if you have new patients, that you can improve the accuracy when new data are available. But in fact, we cannot because of these legal concerns. And I think this is a big difference with the predictive models that they performed previously, like all kind of logistic regression tools where you have these point scores. And it has been developed. Most of them didn't have any validation, and everyone just uses it. And for the machine learning and this artificial intelligence, it seems that everyone is a bit more afraid because we use a lot of patient data. And I do understand that we need to have some regulations, but it might be the cause why it's that difficult at this time to use it in clinical practice. I think at this time, the clinicians are more or less ready to use it. This has been something that was difficult during the previous years, but now we have to go further and try to implement this in clinical practice. But
yeah, I agree with you. It's definitely a legal issue. I just saw a paper, I think in Circulation or so, where they assessed ECGs actually in the emergency department,
yeah,
and prediction of, if patients have basically a acute coronary syndrome, that would be really like a step forward, I think, to aid basically these young doctors in the emergency department in the prediction of ACS. I think Wisit wanted to comment as well.
Yes, I want to add this point that what area of AI that we already implement in clinical practice. I would mention about in US standpoint. So in US, for sure that I have seen, in addition to the efforts to incorporate in electronic health record, is the image analysis. So the especially like those like CT, MRI, chest X-ray, and EKG. Nowadays, at Mayo, there are like AI models that are already like interpret and give the prelim interpretation to us, to the radiologist, to help like confirm. And especially from the nephrology standpoint, we use the AI software to help like measure the like PKD, polycystic kidney disease, like the total kidney volume. We use AI already for that as well. We also incorporating AI into the kidney stones identification and also the AI software to tell that is the kidney stone like uric acid or non-uric acid type. So that's already happening here at Mayo Clinic as well. And also for AI we also use for like organizing work, like send the calendars for our the clinical the appointment for the patients and reminders or something like that. For enrolling in the patient in the clinical trials, there are also ongoing efforts that they're trying to do it here to use AI to help identify patient and enroll the patient into the clinical trials better. And what I think that is gonna the come soon and the soonest is using the large language model or generative AI into like the clinical practice. But of course, there are so many the like ethical and privacy concerns that Dr. Kronbichler also already addressed in his paper.
Yeah, I think we were talking about kidney biopsies, and of course, if you just rely on the machine, I think basically all the pathologists are gone at some point, and all the experience is gone, and that might become, or is definitely becoming, a big issue, and especially, there is a legal concern around that, I'm pretty sure. Okay, so one last short question is, and that was also pre-posted to us. So given that AKI is a complex condition with multiple underlying causes and variables, how accurate is your actually system or your paper? Because you have included COVID-19, cardiac surgery associated AKI. Do you think you would need to focus more on one specific entity here for mortality prediction?
Yes. So what I will say is, and I think if I'm reading it correct, is the one, it will take much time to get AI for predicting mortality of AKIs in low resource countries. Is there a way which we can help? That's exactly what you're trying, or
Yeah.
I think there's another question too. So here's the point that which our group was so focused on the mortality. You have to understand these models are performing in a heterogenic model. Like one is COVID in the pandemic, one is with cardiogenic. Even then, these models are predicting the mortality. I work through ISN with a lot of LMIC, and we have done a lot of work. We just had the Asian group published a whole pediatric data on AKI. What I will suggest in the setting of LMIC, where you rather look for the model that can help you to rule out or to predict who the patient's not going to die, rather than looking into the mortality. Because of the resource limited setting, the mortality is already high if you look into your setting. I will rather use the PCM model, where you can define, you have a control, what are the factors you'll take into account. You have a control on confounders. You have a more control what kind of patient population you're looking into it. We are working in an AKI in the setting of malaria, where we are looking into the models to predict the outcome. And in that case, I will have rather a PCM model where I know the population, look the risk factors, rather than going into the models which will predict mortality, which is always high. Always remember, the more outcome where you see the models performing in a heterogeneous population, you rely more on them rather than looking into the model which is just done on a single cohort. And AUC we talk about, if you look into it, logistic regression is not bad either. So it's not about the model that you will take, which will replicate in your setting. I think you should take a model which is more heterogeneous and have more higher AUC and more responsible, and use them in your setting. So it doesn't matter you are from low resource or high resource. In COVID-19, we were worse. We didn't have a machine to dialyze patients. We were doing SLED. So every setting can be different. Any model what you use, make sure it performs in a heterogeneous environment. It can be predicting mortality in a different setting. You rely more on that rather than looking into the modality where you have single cohort. And that was the whole rationale of putting this study together to look into the heterogeneity and telling you even PCM is not bad either. As Dr. Vlieger was saying before we had this, is not about AUC. You talk about negative predictive value. So in your case, I will have more negative predictive value models, which will tell you your mortality is less. So you limit those resources, rather you focus on the patients who have a high mortality and you direct your resources to that.
So with this, I think we are coming to an end of a very interesting academic hour. I would like to thank the author, Dr. Raina, and the panelists, Dr. Cheungpasitporn and the Vlieger, for staying on, and all the attendees who actually stayed to the very end and asked a lot of important and interesting questions. With that, I would like to close the Journal Club and thank you. And we will reconvene after summer break in September with the next ERA Journal Club. Thank you very much.
Thank you. Thanks a lot. Thank you for giving me an
Bye.
opportunity.
Thank you. This is nice.